So now we switch to English, and you will have the pleasure to hear different accents in this language. I have the pleasure to chair or moderate this session, and we will have the main question of trying to map what are the place, what is the what is done in terms of human and social sciences in different projects, national projects or other projects in different countries. So we are going to travel virtually, and we start in France with Inês Amado, who is in charge of the international part of the French genomic medicine plan. And they will make a duo with Cécile, so please come here too. And I will give you the microphone afterwards. And Cécile is a jurist and specialized in health law and research law. And she is actively working in the CAD, the collector and analyzer of data in the French plan, and they will try to explain us how it is the relations with other countries and other national projects related to genomic medicine with the French plan, and Cécile will specifically address the more human and social science and legal aspects. So thank you very much.
Good afternoon, everyone. So I was asked to present to you what's happening around the world. In French, in genomic medicine initiatives. So I will try to give you an overview of what's currently happening. So there is many different types of initiatives, but we should make a distinction between them. So first of all, is there focus on research, on a research setting or in a clinical practice? And on the other hand, do they screen general population or patient cohorts? So let's start with the genomic programs that are currently screening general population. So I picked out a few examples. So let's start with Europe. There is the Estonian biobank that it was launched in 2001 that has been screened already 200,000 individuals. So it's like 20% of the Estonian population. They screen the health status and lifestyle data that is linked with the national registries and hospital databases. They have around 3,000 genome sequences, and they are currently trying to set up a personalized medicine IT infrastructure. Still in Europe, let's say not far from Europe, the UK Biobank that was launched in 2006 and has screened 500,000 individuals. They currently have extensive environmental, lifestyle, imaging and genetic data that are linked to their health related records, and they can also provide de-identified data to scientists all over the world, as you probably already heard of. If you zoom out more internationally, there is in the United States on the left, the All of Us research program that was launched in 2016. They expect to screen 1 million individuals with to accumulate 250,000 genome sequences. There is an initiative also in Qatar Genome, launched in 2015 with 100,000 expected individuals for 33,000 genome sequencing. And finally, the other example I wanted to give to you is Singapore's National Personalized Medicine Initiative that was launched in 2017. They expect to screen 1 million individuals for a total of 10,000 genome sequencings. Let's go now for the genomic programs that are currently screening patient cohorts in a research setting. So I will give you a few examples. So in Europe, kind of in Europe. There is a project that most of you heard about, I guess, because it was the first one in Europe that started in 2012, which is called 100,000 Genomes Project. That was it has been taken care of by Genomics England. So as the name says, they try to sequence 100,000 genome sequencing, both from rare disease and cancer patients. This was considered this was a pilot project that then is currently being undertaken by the National Health System, the NHS, since they built up a genomic medicine service. In Australia, there is Australian Genomics that was launched in 2016 that is sequencing 5,000 rare disease and cancer patients. They also have this pilot project will be implemented in a clinical setting later, and they are currently this year trying to implement this into their healthcare system. In Canada, which is kind of complicated because Canada has a lot of regions, they are trying to build regional genomics capacity, promoting the equitable and ethical uptake of precision health tools and address barriers to data sharing. So they are trying to link the different regional initiatives that we have around their territory, let's say. What about the national genomic medicine initiatives that go, most of them at some point, through the healthcare system? They are mostly concentrated in Europe. So as I told you, there is the pilot project of Genomics England in the UK that has been integrated into their national genomic research library. In Sweden, there is Genomic Medicine Sweden that was launched in 2018, in which they connected their 7 regional genomic medicine centers as a primary contact point. They built up a joint national infrastructure that they called a data lake, that is their national genomics platform, that can do analysis, informatics, and share data, and they are focused on rare disease, cancers, and infectious disease. The Danish National Genome Center, you will hear later on, or tomorrow, yes, both, because Lene is here, so I'll not give you too much details, but they have this amazing initiative that is built around 2 sequencing centers and a high-performance computing center, and they have a new national strategy for personalized medicine, and if you have any questions, you can ask Lene, that is here, and listen to her presentation, both of them. In Germany, there is one of the most recent, it's the Genome DE, so they have this national strategy for genomic medicine. It's a very complicated case, Germany, because they have their landers, so, and their public system it's not exactly for this type of sequencing is not exactly completely public, so they are trying to connect all the dots and have a national strategy focused on rare diseases and cancers. And then there is France. So Frédéric already told you a little bit about the French Genomic Medicine Initiative, so I'm not going to go over it again. You also know that all these European initiatives are being connected at the demand of the European Commission by this initiative of 1+ million genomes. The idea was to sequence 1 million genomes in Europe until 2022. It's 2024, we still don't have 1 million genomes, but we are still working together to build on it. The idea would be 500,000 of rare disease and cancer patients and 500,000 of general population. And the European Commission, just like Frédéric said earlier, have already supported, financially funded different pieces of the puzzle of this initiative. One of them is the European Genomic Data Infrastructure. The other one is the most recent that Cécile is going to maybe quickly go over it, Genome of Europe. to create a general population cohort in Europe, and there are 2 projects ongoing. One is Can Heal, to build a platform on cancer that is piloted by Thomsen. Someone is here, Chloe is here, I think, from Thomsen. And the European Partnership for Rare Diseases, that is, so we have cancer and rare diseases, these are the focus. So in terms of collaborations, at the moment of the French initiative, we had signed different agreements with England, Genomics England, Genomic Medicine Sweden, Danish National Genome Center, and we have 2 collaboration agreements in preparation, one with the NHS, so the National Health Service in the UK, and the other one with the Netherlands that don't have a national initiative yet, but they are very implicated in the genome sequencing, and they are willing to work with us. So if you have any questions in French or in English, never mind, if not.
I'll go into more detail for the 1 million genome initiative. So, like Lisa said, with the creation of the European Health Data Space, a lot of governance discussion has been postponed to include everything from the European Health Data Space and any recommendation from the European Commission. So all these elements are still in discussion. In the healthy group of 1 million genome, we are mainly talking about data governance with the data access committee to the health HDAB, which was shown, and every recommendation that are asked by the countries on the EDIC task force. I don't know if we specified what EDIC was. It's a European Digital Infrastructure Consortium. So most, if not all, of the country of 1 million genome decided to join to create juridic body to be able to have an existence at European level and to make law or influence regulation for the European Commission. For data inclusion, I will talk about a little bit of Genome of Europe because the main discussion is about what kind of data we want to include, if it's opt-in data, opt-out data, consent data. And the main focus on this is some country, like France, have already sequenced a lot of people compared to other, and it would be a great effort to go back for consent of every patient that we have sequenced. The important part also is the distinction between health and research. And with this distinction, we have the problem of incidental finding. All these discussions are currently being overviewed at the EDIC level because it implies a lot of influence on access and what can go out of the research. One of the points which came back from discussion at EDIC and EHDA's discussion is the obligation of publication with access to the data and also open access for the publication. The question of dynamic consent has been postponed to a later date because it's very, very, very complicated to make everyone happy with this. So to be clear on what we have to take care of, it's a little bit complicated, and when you take everything into account, you have other layer of political question which complicate everything else. So most of the discussion about distinction is, like I said, about access requests. So principally, how can we identify the people which will access data? What will be the purpose? How can they describe their research? And when do they have to do access request? It's the same discussion for approval. So most of the country, as you may have guessed, want to have national approval. So it's very complicated to make everyone happy with what has to be in the review to be approved. And consequently, for data use governance, which part of which body in the country will have to decide who have access and which on what criteria. So, Lisa, what is envisioned at 1 million genome is the EDIC recognized as the data sharing infrastructure explained in EHS. So for now, but everything is in discussion, Genome EDIC could join EHDS as a partner, but they have to work together because genetic data has not been explained at the level which is needed for GDI. So a lot of the access part has not been included for genomic data. A little about on the LC group, we worked on the response at World Health Organization. They published the principle for human genome access and use sharing. So we've made and participated a response for multiple principles which have been laid out. We asked for clarification on certain points, but approved most of them, principally on the life cycle management, on the balancing between individual and societal and stress, because there was a lot of talk of communities in the document, but it was very difficult to understand what they mean behind it, and to promote the best interest of individual, because most of the individual sequences are patients, so they are vulnerable. Thank you.
So then it's complicated. Yes, we understood that. Okay, are there questions or clarifications? Yes.
Yes, I'm Lene Cividanes from Denmark, from the Danish National Genome Center. Thank you for a very interesting presentation, and also thank you to Lisa, who did the one on EHS and GDI, and I was actually wondering how you're organizing the collaboration between GDI and EHS in France. I mean, it's most likely in different ministries, or maybe in different ministries, and it's different organizations, and how are you making sure that you're developing in the same direction, and it will be possible to have both of them in one organization maybe in the future?
So one of the requirements to be included in the EDIC task force was to have connection with the representative in the EHDS group, which is for France Health Data Hub. So we have a monthly meeting with them and exchange information on everything to be able to coordinate our effort.
Thank you very much. I would like to know if it's in the project 1 million genome, you include a collection of data on a longitudinal way to follow the actionability of incidental findings, as you know, to have a confirmation of the beneficence for individual and for a public policy also, health public policy.
Yes, so the question of incidental finding is a very difficult one because it means that we have to conserve the link between the patient and the data, but at the same time we have an obligation to have pseudonymized, anonymized data. So that part has been postponed in the decision because it needs to be in the... For now, the choice has been made to for the patient to be able to opt in or opt out of research by a portal, and that portal is not yet operational.
Guillaume Congan from resident in Paris. I have a question, I guess, for the first speaker. So I know that the All of Us program is trying to include underrepresented countries funded by the NIH for, I guess, ethical and medical purposes. Is there any aim like this in Europe with the various projects you've presented?
I'm sorry, I didn't get it. Another, besides 1 million genome initiative?
No, so the All of Us program.
If Europe is financing.
No. If Europe underrepresented countries in Africa, for example.
Well, there is even in the French initiative, there is an effort to represent minorities in all the screenings that are actually being done. So everything that's going to enter into the genome of Europe, so that will be the European cohort for general population. It has been, it is discussed and it has been taken into account, but it's mostly, from what I understood, representation of what of the population that lives in each country. So not like you were suggesting that you can screen out other populations. Then there is Qatar is doing something in Singapore. They are trying to screen general population, but not yet patients. But it's still very vague for the moment.
I can say something about that. That's a classical discussion between the epidemiologist and the geneticist, population geneticist. The epidemiologist, well, I'm making caricature, of course, but epidemiologists see the population as it is today, with all the components. And it has to be as best as possible representative of what exists. Population geneticists, because of they want to have the ancestry and to know from where the people are coming. And if you mix up different origin population, there are a number of calculations that you can't actually do because the hypotheses behind the calculation are not respected. So there are really these two things, and projects like Genome of Europe is really facing this dilemma. Do we act as epidemiologists, but there are a number of things that will not mean anything in terms of genetics, or do we act as population geneticists and we are fired by people defending minorities, saying that they are not represented enough and so on. So that's one of the societal, ethical and methodological mix-up questions. Other question? No. Okay, then, thank you very much. Now we start our travel, and I will call Lene from Denmark. So, while I'm just presenting you very shortly, I want to mention that the short biography of all the speakers, the invited speakers, are available on the website of the event. And some people ask, will we have access to the slides? And that will be the case. I thought it was me. So Lene, how do we pronounce your name? Cividanes? Can be that, like that, with the English. Is the head of research and international relations at the Danish National Genome Center. And by training, she's a political scientist. And you have more on the biography, but I think that you are going to intervene shortly now. And then we will go to your colleague who is in Denmark. We will be online. And you will continue in more detail tomorrow. Thank you very much.
Well, thank you very much. Well, I will, as Anna just said, very shortly present the Danish National Genome Center, the Danish strategy for personalized medicine today. But then I will go more into depth tomorrow when I will present our take on health economics and the Danish National Genome Center in general. But today I will focus on social sciences in the strategy in Denmark. And I will start out with my point of view of how we're doing it in the Danish National Genome Center, and then my colleague Ivana, who's online, will talk about a research project with a lot of social scientists involved in Denmark around the strategy for personalized medicine. And first of all, the Danish National Genome Center was established back in 2019. It's actually quite similar to the French initiative, and we didn't even know each other when we established the Danish initiative. We got to know each other, I think, in 2021, and we realized that it's actually two initiatives, I think I could say, in the world that are most similar. It's also top-down in Denmark. We focus on coordinating the implementation of whole genome sequencing in the healthcare system in Denmark. So we did not do any research project like they did in the UK or anything. We just started directly implementing whole genome sequencing in 17 different patient groups in Denmark. And then the data that is sequenced in the healthcare system in Denmark is then by law reported to the Danish National Genome Center, where it's stored in a national genome database. And then this data can actually be accessed by the clinicians, of course, for the use for the patients, but also by researchers in order to generate more or new personalized medicine. And of course, it's consented in the healthcare settings when it's collected. And then we run this high-performance computer where we store the data and where the data can be accessed in secure processing environments. And last but not least, we have to help the Minister of Health in Denmark to promote personalized medicine in Denmark, and we also represent Denmark in a number of international forums, including the 1+ million genomes that we've heard a lot about today, and the Genome of Europe and the Genomic Data Infrastructure, etc. The Danish National Genome Center, we thought about a lot about including social sciences all the way from the beginning, and we thought it was really important to look into inclusion of citizens and patient engagement and look into all the ethical issues. So we decided to have an advisory board for patient, citizens, and ethics, where we have 10 specialists from around the society, both from ethical side, from patient side, citizens, etc., representing at different organizations, and they discuss all kind of social science-related issues to advise the Danish National Genome Center. And this is the advisory board. We also have other number of advisory boards, and we have a lot of clinical groups representing the different areas or patient groups where we have implemented whole genome sequencing. But as I said, I will return to the Danish setup tomorrow. So what are the things that we're discussing in the advisory board? Well, first of all, in the Danish National Genome Center, we're actually not allowed to do research ourselves. So we don't have a lot of research project in the Genome Center, but research can be done outside the Genome Center, and they can look into us, and they are also involved sometimes, for example, in our advisory board. So in the ethical advisory board, we have a representative from the research project that my colleague will tell you about afterwards. And this is just to give you an example of what has been discussed in the advisory board and what we have implemented after advice from the advisory board. So for example, when we had to develop the consents, we had ethical discussions in the advisory board, we had legal discussions, we had discussions with other centers for ethics, with patient groups, etc. And together with the Danish regions who are in charge of healthcare in Denmark, we developed a consent, which is the same consent all over the country. And it's stating that the data can be used for secondary use. So it's actually not an option to say no in Denmark in the first place. If you want to get a whole genome sequencing done in the national healthcare settings, then you are obliged to give your data for research. But then afterwards, when you've got your result, you can actually choose to opt out and say, okay, my data cannot be used. I think this is quite a special setup, and it's not seen in many other countries, but it works quite well, and patients are actually quite satisfied. Then, of course, also, as we heard in some of the presentations today, equality in access to whole genome sequencing has been discussed. It's really important for us to have equal access across the country and across different patient groups. And you can, of course, always discuss how to do that, and if it's actually possible. Sorry. So it's different things that we've been discussing in the advisory board. So we think in the Danish National Genome Center that we've been quite good at including these different social sciences take. And we're also representing the Danish National Genome Center in the ELSA group that Cécile talked about, in the EDIC, and all those discussions ongoing at the European level. We have hired both legal experts and one geneticist and one anthropologist with expertise within ethics working directly at the Danish National Genome Center. We've worked, as I told you before, on the informed consent together with a large number of specialists. We have formalized collaboration with this Danish Agency for Ethics. So we think ourselves that we have really included social sciences. But if you look from outside, then people might slightly disagree. And this is what my colleague will tell you about now.
If you just let me introduce you. You are Ivana Bogicevic from Denmark. Should have been here, but could not come. And so we have the opinion now, or the vision of a social anthropologist who is also a special advisor at the Danish National Genome Center. So please, Ivana, just continue.
Thank you, Anne. Yes, so as Lene mentioned briefly, before I was hired at the National Genome Center, I was a PhD scholar in the project called Personalized Medicine in the Welfare State, or MINWI. The project was led by Mette Nordahl Svendsen, a professor at University of Copenhagen, and it was funded by the Carlsberg Foundation and running from September 17 to June 24. In the project, we were 15 scholars, or 15 projects in total. And across all the projects, our focus was to explore how strategies of tailoring diagnosis, treatment, and prevention to individual genetic variability challenge existing ethical, organizational, and regulatory frameworks in medicine and healthcare in general. And the project started as the National Genome Center was created. Let me just see if this works. Yeah. In the project, we explored this by following the introduction of precision medicine in both research and clinic related to diabetes, heart disease, and cancer. We also followed the introduction of precision medicine in law, data science, public attitudes toward this, and also in politics. We used multiple methods. Some of us conducted ethnographic observations and interviews, document analysis, philosophy of science approaches, ethics analysis, surveys, and also Twitter analysis. In total, the project has led to more than 50 publications by now. But today I've chosen to focus on how we can ensure a continuous legitimization of precision medicine and other health data initiatives that require intensive health data sourcing and use. So what we found in the MINWI project was that collecting and using data can be viewed as a process of attachment and detachment. When the patient or the health data is in the clinic, we often see this data as attached to the patient. The data tells us something about the patient and her disease and treatment plan. But then in the process of collecting and storing the patient's health data in national databases or biobanks, the data slowly becomes detached from the individual, and instead it becomes attached to the governing body of the database. And in Denmark particularly, the data becomes attached to these welfare state institutions who are now the guardians of the data and can decide over the data use. However, what we found is that these detachments from the individuals are never final. Rather, what we find is that certain data users can awaken the individual's attachment to their own data. And the data is suddenly no longer experienced as belonging to the public and being guarded by the welfare state, but rather as belonging to and representing the individual once again. And these sort of reattachments happen when the individual finds that the data use is illegitimate or not in line with what the individual view as correct ethical frameworks for data governance and use. And one of the things we found that most often leads to these contestations is when data is used far away from the context in which the data is originally collected. And this can either be physically far away, for instance, international sharing and international use of data, but it can also be disciplinary contexts that are far away. For instance, right now we have a current debate in Denmark regarding a project that has used genetic data derived from blood spot samples from more than 140,000 citizens since 2012 to find the causes and create the basis for better treatment and prevention of 5 of the most serious mental disorders. However, during the last few years, this project has started to connect genomic data and other health data to electoral participation. And this move away from health research towards more political science research has actually caused a reaction. And citizens who could potentially be part of this cohort are now demanding to know whether their data has been used in the project. And a majority of these people actually want to withdraw their data from the project. Now, the current debate has not only raised critique of this move from health research towards political science research. There's also a critique about the fact that the project has not obtained informed consent from the 140,000 participants. Now, importantly to note is that when the project was approved in 2012 by the ethical committee, they received a dispensation from informed consent. This meant that they did not have to obtain informed consent, they could just use the blood spot samples. This was in line with the ethical and legal frameworks in 2012. However, what we see now is that the societal norms and attitudes, especially when it comes to the use of genomic data, has changed a lot. And I really think that today it's almost unthinkable to receive an ethical approval to use genomic data without obtaining consent first. Now, the project, when they were met with this critique, tried to stress the fact that they had an ethical approval and they were following ethical and legal frameworks. However, what we see in the debate is that these ethical and legal frameworks cannot stand on their own. And often when we have a dispute about data use, the informed consent becomes what we turn to in order to make the data use legitimate. This also happened with the Genome Center that firstly met a lot of critique, and then we introduced the informed consent, which Lene just told you about. However, what our research shows, and also what this example shows, is that informed consent can also not stand on its own and ensure legitimate use. Rather, what we find is that researchers and public institutions who participate in data sourcing and data use must continuously engage with current societal norms and attitudes, because these can change, as we see with this example. In 2012, it was fine to get a dispensation from informed consent and use genomic data and research. But today, 10 years later, the attitude is different, and you cannot really use genomic data without informed consent. But what's important to stress, and what we found in our project, is that contestation can actually be productive. So one should not be afraid of taking such debate or of asking or engaging with societal norms and attitudes. Rather, by inviting discussion and listening continuously, we can actually create more sustainable and legitimate data infrastructures and data uses. And importantly is that these discussions gain a lot if we approach it interdisciplinary and actually invite for interdisciplinary discussions. In the Mean We group, we held ethical laboratories where we invited both patients and healthcare professionals and policy workers to debate different ethical dilemmas. And what we found in these conversations was actually that people from different disciplines or different backgrounds found out that they often agreed on what was the most pressing ethical concern, and actually also often agreed on how to solve this ethical concern. And this is also something that we find when we work with the advisory board in the National Genome Center. Bringing different disciplines together and discussing problems often leads to more robust solutions and recommendations. So what we find in our both in our research, but also in my work today in the National Genome Center, is that debate must be integral to governance, and we must think this or integrate it in all our initiatives and governing boards, because we cannot just rely on ethical and legal frameworks, because the societal norms and attitudes can change over time, and if we don't follow along, we can end up with a lot of public debates and also people withdrawing from the initiatives and no longer supporting them. Now, besides obviously inviting for public debate and engaging with the public attitudes, what we also find is that the next, if you can say, chapter of precision medicine initiatives need to engage with some of the most important tensions that are right now in order to ensure a continued legitimacy of precision medicine. Now, and I've highlighted 3 important tensions to address. The first one is that we are seeing a very labor-intensive treatments, these, and when you do precision medicine or personalized medicine, that are being introduced in an understaffed healthcare system. So what citizens are experiencing is that this so-called societal contract, where they offer their data to the public institutions, and the public institutions can then use them for research, but in exchange they get free healthcare, which is the example in Denmark. Citizens actually now experience an understaffed healthcare system where the waiting lists are very long, and they don't really get anything in return for this data. We also have a problem of being raised in regards to a lot of these treatments being very expensive, but at the same time, we have an ambition of reducing inequities in the healthcare. And then we also have a tension between this molecular gaze that precision medicine often brings with it, while seeing a steep rise in diseases that are not really resulting from any genetic dispositions. So these are some of the tensions that needs to be addressed in the next chapter of precision medicine, I would say. Yes, thank you.
Thank you very much. Time is very well passing. So if there are some quick questions and quick answers, you are very welcome. English or French? English better.
Hello, thank you for this presentation. It's not a question actually, it's just a remark that I'm really happy to see the convergence with our project in Kenhill too, whereby investigating the patient and public attitude for more than 6 years, we see that in general it's always the same things that come back, and that it's really needed to take those values into account.
And we will discuss that tomorrow at the health democracy or patient involvement session. So now we continue the travel throughout Europe. We go to UK, and Celine Lewis, who is a behavioral scientist, will talk to us about the situation regarding human and social sciences in the UK with different projects. And I think that I will not talk more because we are already late. Thank you, Céline, and the word is yours.
Bonjour, je m'appelle Céline Lewis, je suis en BC en Angleterre à University College London. Et je m'excuse de faire ma présentation en anglais aujourd'hui. I will describe the experience in England. I will start by giving some background information about the situation we have in England with genomic medicine, and then briefly just introduce 2 different projects that have been looking at the social science and human sciences aspects of the genomic medicine situation. Okay, so as some of you will know, the UK has been very central in research and innovation in genomic medicine. So this began with the Human Genome Project in 1990, was completed in 2003, and then we also have UK Biobank, which began in 2006, is a large-scale biomedical database and research resource containing in-depth genetic information from around 500,000 people in the UK. So the NHS is, I guess, quite unique from other countries because it has this sort of very long history of providing services, but also importantly, it's centrally funded across the whole country. So it's not regionally funded like in other countries like Australia or America. The NHS is central to the entire English system. So that enables it to drive through change at scale and pace. And we also have a very vibrant life sciences and industry sector in England with 140 genomic companies, including those companies in Cambridge and Oxford and also London. Then we also have another key driver is that the government, the politics, there is a lot of support in the UK for implementing genomic medicine and for the life sciences, and there's been a huge amount of investment in genomics over the past 10 years. So all of these things really come together and ensure that the NHS can sort of remain at the forefront of genomics. So in October 2022, the National Health Service published the very first genomic strategy. It's a 5-year strategy that set out the vision around the power of genomics in preventing and diagnosing disease, but also in targeting treatment. And so what they want to do is embed genomics across the entire National Health Service. They want to deliver equitable genomic testing for cancer, rare disease, and common disease across the country. They want genomics to be at the forefront of the data and digital revolution. And they also want to develop this kind of cutting edge research and innovation industry in the country. So as was alluded to before, you may have heard of the 100,000 Genomes Project, and this was a proof of concept project conducted from 2014 to 2018, whereby patients affected by undiagnosed rare diseases and cancer were invited to have whole genome sequencing. And it was a hybrid clinical research model, which meant that if you signed up to take part, you would have whole genome sequencing for a diagnostic purpose, but you would also, you were contributing your data for research purposes. So you had part of signing up was that you agreed for your genomic and health data to be used and analysed by researchers. And there was also the option of having secondary findings returned. And really this lay the ground for the genomic medicine service in a number of ways. So it transformed elements of the NHS to enable the introduction of the genomic medicine service. It built the evidence base for whole genome sequencing as a diagnostic test. It established a mechanism to collaborate with industry, and it pioneered the sharing of de-identified data and was a springboard for what we called the National Genomic Research Library. And we were also able to show what the diagnostic yield was, and we found it was, at the moment, it's been around sort of 25 to 40%, depending on the clinical, what condition that patient has. So then after the 100,000 Genomes Project, the Genomic Medicine Service was launched, and the way that this works is the country is divided up into 7 sort of genomic laboratory hubs, which are commissioned nationally with an embedded function, which are delivered by these what we call Genomic Medicine Service Alliances. So their role across the country is to embed genomics into routine care. And then the idea behind this as well is that there were these principles that are driving this, which is around sort of involving patients and public at all levels. So inputting into the way the service is delivered, the information patients received. There's a standardized model for how we deliver and contract the service. It's clinically and scientifically led, which means that as new genes, for example, become identified as being important in the diagnosis of rare diseases, they get added to the panels that we're using. And the idea is that really we're sort of informing and driving change and using data all the time in a sort of we're embedding the sort of insights that we have into the services that we're providing. And then this new approach to genomic medicine is sort of beyond a small focused approach where all genetic cases are seen by clinical genetics. So what's now happening is that the idea is that genomics is much broader and that any clinical specialty can, in theory, order a genetic test as long as it's specified in this, what we call a national genetic test directory. So a genetic test can be ordered by a medically qualified individual who is specialized in a discipline other than genetics, and that includes in both primary and secondary care. And we've called this sort of mainstreaming genomics, and the idea is that it will provide a more equitable service to patients across the country. So for example, it doesn't have to be a geneticist who might order a whole genome sequencing for intellectual disability, but it might be a neurologist or a pediatrician or someone in metabolic medicine. So sort of it's multi-specialty, multi-professional, and it involves a cross-professional involvement in multidisciplinary teams. And like I was saying, the idea is that we're enabling sort of equity of access by having this national genomic test directory, which mandates what conditions can be ordered. And there are approximately 3,200 rare diseases covered in the test directory and over 200 cancer indications. And it's constantly being updated with new genes being added to the panels. And as you can see here, the idea is that the testing covers the complete life course. So as well as diagnostic testing, it also includes pre-symptomatic, predictive prenatal test, includes non-invasive prenatal diagnosis, and it also allows the function to go back and reanalyze whole genomes in the case of diagnostic discovery. And last year, there was approximately 38,000 rare disease tests that were conducted. And you can see it's been available now for over 33 clinical indications. And we also have a national rapid service, including rapid whole genome sequencing for acutely unwell children in the neonatal intensive care unit. And one of the things that Genomics England and NHS England are doing are using the data to monitor the progress. So they're able to look at who is it that's accessing the tests. Is it being offered equitably across the country? Is it being offered equitably amongst different population groups? And all of the Genomic Medicine Service Alliances send in that data, which is collected centrally so that they can monitor the service provision at both sort of a population level, look at geographies and where the greatest need is in terms of eligible conditions or populations. And this data, as I said, is sort of returned on a monthly basis so that we can keep track of all of this. And so now I'm just going to, with that as sort of a bit of background for you, I'm just going to go through a couple of sort of initiatives, and this is really a big national initiative that's recently kicked off. And so in 2022, the UK government announced it was awarding £105 million to kickstart a world-leading research study, which was led by Genomics England. They were the ones that also led the 100,000 Genomes project. They're a private company, but they're wholly owned by the Department of Health. And the idea was to explore the effectiveness of using whole genome sequencing to find and treat rare genetic diseases in newborn babies. So essentially, it's sort of genomic newborn screening. So the aim is of the study will sequence the genomes of 100,000 babies over the course of the study, which is 18 months, and it started at the beginning of this year. And it will gather evidence to consider whether we should be offering genomic newborn screening across the country and whether this is something that should be funded through the NHS as a national service. And there's 5 primary research questions that are being asked as part of the Generation study, which is the name that they've given for this genomic newborn sequencing program. They want to know if the use of whole genome sequencing as a tool for early diagnosis is actionable, feasible, and acceptable. We want to look at sort of the clinical utility of genome-led newborn screening. So looking at sort of how many screen-identified diagnoses are there compared to sort of standard care. We want to look at the cost effectiveness of genome-led newborn screening compared to standard care. We want to look at the impact, so both positive and negative, of the program on parents, on families, on clinicians and health professionals, and the wider system, and sort of also gather information about stakeholders' experiences and attitudes for whole genome sequencing. And that's really, I guess, where I come in. So they put this out for tender, this kind of, they wanted this sort of process and impact evaluation not to be done in-house. So what they did was they put this out for tender, and there were a number of different institutions and universities that applied to do this evaluation work, including UCL, where I am, and we were fortunate enough to win the tender to do that. And so I've put a team together at UCL, as well as a number of other universities to conduct this research. And we've got social scientists on board, implementation scientists, health economists, and data scientists. And it's an 18-month project that began last December. And this is really just sort of an overview of what the sort of various sub-studies are. So you can see here in this evaluation, we've got study 1, which is understanding the goals and challenges. And what we're doing is we're using implementation science methods to understand sort of what some of the early challenges and barriers have been in implementing this service. So we've been doing qualitative interviews with those people that have designed the genomic medicine, the generation study, but also people who have sort of strong or sort of experts in the area that are quite vocal on genomic newborn screening. And we're also shadowing the early sites that are starting to recruit parents for genomic newborn screening. So we're sort of looking at what impact offering genomic newborn screening is going to have on antenatal care and the current health service, how much time it takes to have those conversations, what those conversations look like. Then we've got the second study, which is looking at the experiences and attitudes of parents themselves that are being recruited to take part in the generation study. And this is a mixed methods study where we're going to be sort of using both surveys with validated measures as well as qualitative interviews to answer questions such as, is whole genome sequencing as a tool for early diagnosis feasible? Is it acceptable to parents? What are the wider positive and negative impacts on families, including parental mental health, and can we return these findings effectively using the approach that's being adopted by the generation study? We're going to be gathering wider professional viewpoints through a survey. So we're interested in finding out from health professionals whether they think genomic newborn screening is sort of feasible and acceptable, what impact it's had on their service, if any. We're also doing work with the rare disease community. So we're doing a survey with over 200 patient organisations in the UK to see what they think about genomic newborn screening, whether they're prepared for supporting families who get a diagnosis through genomic newborn screening, and what impact they think it might have on their organisations. We're doing some public views work using a survey with a market research company. We're doing a cost effectiveness analysis using microcosting of survey responses to look at what the impact is on secondary healthcare resource use, including estimates of end-to-end costs from recruiting through sample collection, sequencing, and interpretation through to clinical care. And lastly, we're doing a clinical utility assessment using Genomic England cohort data linked to administrative data to answer the question, what are the positive and negative impacts on health-related outcomes in terms of morbidity and mortality? We've published the protocol for our evaluation in medRxiv. That came out about a month ago, so it's available if anyone wants to have a bit more of an understanding of what we're going to be doing over the next 18 months. And then I guess the second study that I thought I would just briefly present to you was an example really of a more individual initiative. I think really sort of the evaluation that we're doing of genomic newborn screening is the only one I know to date which has been which is a sort of a national initiative that has been funded sort of through the Department of Health. And this is this one that I'm presenting here is funding that I received as an individual in the form of a fellowship. So what I've been doing is a mixed methods evaluation of the genomic medicine service, but I'm particularly interested in how we're using whole genome sequencing for pediatric rare disease. So you may remember I talked about at the end of the 100,000 Genomes project how we now have a genomic medicine service where patients can routinely and freely access whole genome sequencing as part of routine clinical care. And so I was very interested in understanding what that was like for what impact that was having on parents and the benefits and clinical as well as sort of psychological, social and behavioural impacts of receiving whole genome sequencing diagnostic results. And this was a fellowship grant. It was awarded, it was around £800,000 funded through the National Institute of Health Research, and the National Institute of Health Research is the UK's largest funder of health and social care research training, and it's funded through the Department of Health. So in a way, it's kind of a research arm of the NHS, and they give out individual grants to organisations or individuals. And I was lucky enough to get one of these grants back in the year 2000. And this really is just a brief overview of what that study looks like. It's actually fairly similar in terms of the study design to what we're doing in terms of the genomic newborn screening evaluation. So we're doing interviews with people that design the genomic medicine service, as well as genetic specialists about their experience of rolling out the genomic medicine service over the first couple of years. And we're also doing interviews and a survey with parents who are going through whole genome sequencing to understand their experiences and outcomes. We're also, I've been doing observations of families being consented for whole genome sequencing, and I'm also, as well as that, I'm also observing parents receiving results from whole genome sequencing. So I'm really sort of trying to get sort of an overview of the whole process from consent through to results return, and how that's being done in the health service, and what parents think of it, if it's being done, you know, whether it's being done effectively, if there are things that we could improve, whether we're giving information in a way that's understandable and avoid sort of any kind of patient harm or concern. And then again, I'm also sort of very interested in the idea of mainstreaming. So I've been doing a lot of work with non-genetic specialists about their experience of being tasked with consenting and delivering whole genome sequencing results, because that's obviously very new and something that's not happened before. So this idea of mainstreaming, I'm particularly interested in that. So that work's been published in this protocol, and thanks for listening.
Thank you very much. So we have a lot to learn from each other. That's my comments to all these talks. Is there any punctual, quick questions?
I was just wondering, all the first studies the impact studies you explained about, how were I didn't understand how they were financed, because I mean, as I said, in Denmark we're not allowed to do research ourselves. I tried to be a bit proactive and say we did everything. My colleague was supposed to say we didn't do everything, but I mean, did the initiative finance the research themselves, or how was it planned all the way from the beginning, or how was it?
Which was so for the 100,000? Which project in particular were you referring to? Sorry.
You had a slide with a number of projects where you did interviews and different things, and you called them impact studies, I think, or something.
So yeah, I mean,
yeah.
So the impact of the newborn screening is being funded through NHS England. And that's a sort of, that was a national initiative. And the second one that I presented, that's a sort of fellowship grant. So it's an example of a sort of individual initiative, if you like. So.
Yeah, thank you very much for your talk. If I understood properly, you are screening with newborn 200 plus conditions?
Yeah, that's correct.
That's a lot. And actually, my question is, how did you reach an agreement on these 200 plus?
Yeah, so I mean, I wasn't involved in that, and I haven't been involved in deciding what the conditions are. That was developed by sort of a consensus approach with experts in the rare disease world, and it has been published actually. I haven't got, I'll try and find the link to the publication, but they went through a sort of Delphi process where they involved experts, patients, and families from a huge number of conditions and whittled it down to 200. And the aim is that they wanted to include conditions where where there was sort of actionable sort of treatment or therapy that could be used, and that the condition affects the children in the first 5 years of life. So they're not going to be returning any adult onset conditions, and they're not going to be returning results for conditions that aren't treatable.
Thank you. The question was from Gauthier Chasson, who is a jurist in our team here in Toulouse, just for you to know. Any other comments, questions? Nothing? Okay. Thank you very much, Celine. And now we jump, like in Harry Potter, just very quickly to Austria. And we are going to listen to Michaela Meyerhofer, who is political scientist by training, and I make it short, and has been since the pre-existence of the European biobank infrastructure involved in this. So she will, through this experience of more than 10 years, she will explain different aspects of the genomic medicine through the biobanks, and she is given an appetizer title, include ethico-societal dimensions when thinking interoperability. Now I'll let you know what is behind. Thank you.
Thank you, Anne. Thank you, everyone. I would like to use this talk also to talk briefly what BBMRI-ERIC is. It is a federated European research infrastructure for biobanking. It brings together many players from the biobanking field. So besides researchers and the obvious biobankers, also from industry, patient groups, citizen groups, and the whole goal, the ambition, is to boost biomedical research. This can only be done if you have and promote data quality management services. Otherwise, it's garbage in, garbage out. When you support the ethical, legal, and societal issues and provide a number of online tools and software solutions. What you see with this statement that is on the website is that it is very much tool-oriented. And as we know, as social scientists and all those, doing things, a tool can help, but it cannot be the solution per se. So the whole old philosophical conundrum, a hammer can be a wonderful tool, but in another context, it could be a weapon or some nice thing that just lies around unused, which according to biobanking is actually the worst. Now, the biobanking research infrastructure that is now 10 years old and was succeeded by a 6 years preparatory phase, 3 of them actually funded through an EU project, another 3 years put together with blood, sweat, and tears by those scientists from all fields, including biobankers, including biomedical staff, including ELSI folks, was continued. Eventually, in 2013, in December, our statutes were approved by the Commission. Officially, it started in 2014. And today, it has 20 member states and 5 observers. What you see there is that the members of this European research infrastructure are member states, represented by the Ministry of Health in most cases, sometimes by research in most cases, sometimes by health, and very rarely with even a combination of the both. And then 2 delegates need to figure it out how to speak in one voice in our annual assembly. And speaking of many voices comes together when talking about ethical, legal, and societal implications that constantly, as we have heard also before, need to be renegotiated, readdressed. So if a solution is found, it works maybe in one context, in a specific moment for a certain time, but then needs to be readjusted. And that is very often the imaginary that we face, as if we could set up a structure that is permanent, a tool that works for all conditions that we face, all issues that we have, or the ultimate dream in today's world, very probably one vaccination that cures everything with one shot. Where I'm heading with this is to focus a little bit more on our community. And the community is today about 400 biobanks, affiliated partners, national nodes, expert groups on LC quality and IT, expert centers, and the headquarters which I represent, which is situated in Austria, and tries to bring or provide a platform to have these discussions across the various voices across Europe. Now, for those of you who know already BBMRI, you might note that we talk here about 400 biobanks, and in previous slides we always said about 600. Well, reducing the number of biobanks that we showcase in a directory, which can be compared to a phone book for biobanks that are all over Europe, represented by the orange dots here, is that the reduction of numbers in some countries is seen as something positive. So, for instance, Finland combined its biobank within one national service, whereas it had a couple of them before. Other countries go the opposite direction and say, we continue the regional aspects. Austria here is an example. It's not comparable to the German Länder, but even a small country of Austria with a population of about 8.5 million has 9 regions and 5 medical universities and 6 biobanks within the country. All of them are then interconnected, and you might have guessed, in each country it works slightly different. And when we solve the technical aspects, we might overlook, or the threat certainly, the risk is to overlook the ethical, legal, and especially societal aspects, the culture that is in the organization that collects it. Do we have the plan to collect it? Yes. Do we have the funds? Yes. Does it reach the people, and is there the manpower to actually do it? That might be another question. How to convince a study nurse, a biobanker, a surgeon to add additional multiple variations. And then what is a biobank? Here, the old differentiation across the country still prevails, population-based versus clinic. What is the speciality of the clinic? The imaginary that the biobank is one whole item, but rather it is a compound of multiple collections with often very different consent forms, changing with the study over time, and so on and so forth, especially when it is coming from the clinical setting. What I still want to say with this slide is that BBMRI has its own legal entity, and this is ERIC, European Research Infrastructure Consortium. It was created for research infrastructures on the S3 roadmap, and recently ethics are also coming up. So where I'm heading with this statement is from a political science perspective, competition comes in. Why is an ethic needed? Does this help? What does this do to the socioeconomic impacts in following seemingly the same goal, allowing access, easy access for those who need it, say for research, and then of course we intersect again. Who has access? Who can decide who has access? What are the national strategies? Again, they differ. Now, finally, talking about ELSI within BBMRI, since 10 years we have the ELSI Services and Research, previously called Common Service ELSI, where we have 3 columns: research, service, and training. we say that research is necessary, funded through research projects, most of them European, on the Horizon projects that lead to publications that allow us to collaborate with the concrete, and whatever results come out are translated into services to provide help desk answers when queries are coming in, to maintain a knowledge base, to help with ethics checks that are building, that are the requirements within Horizon 2020 projects. And training, public as well as tailored workshops, where we have certain training events, say, also paid for the industry, but also ELSI dialogues, which can be watched on our YouTube channel. Same as for the podcasts on the various podcasts channels. Now, going more into the concrete, I want to talk briefly about some of the projects that deal with EHDS and genomics that BBMRI is directly or through the periphery involved. So for TEDAS, for instance, BBMRI was not involved as a participant. We could not, as we also were not the representative of the country. However, as it was a joint programming initiative, however, we are here, the stakeholders who are requested to provide insights to service, to public events, and so on. This is not only on the headquarters level, which I represent, but the wider European level. More concrete projects are EHDS, concretely EHDS2 pilot that deals with secondary use of data, so the research elements. And here we lead the IT and ELSI work package. And I'll tell you an interesting story about that in a minute. The other two projects that I've mentioned is the preparatory project or smaller initiative on the B1MG, where ELSI received some funding to prepare and contribute to the concept, what then later was fed into the wider, bigger European strategy that was then also approved, and we already heard about across various member states. And a project that should provide the concrete is the European Genomic Data Infrastructure, GDI, where again, BBMRI is a participant in the project. To my big regret, only IT is part of it. Why I'm using these projects here is to showcase that a lot is going on, that from the European research infrastructure perspective, the question is, how can these projects interlink what has been built up with the biobanks without outliving them, but connecting and interconnecting them? Because the problems when it comes to who has access policies, incidental findings are largely the same, and there is something to build up on. Also, the question is, if there are interconnections, we have some biobanks who have storage of genomic data, how are they then integrated, especially in the lack of a national strategy, if at all, into the wider realm of the Genomics Initiative or EHDS? Now, talking more of what can be done, European research infrastructure always has a political element to it, and that is also an activist one, where we as an organization can come together and respond, say, to the new WHO principles for human genomic access, use and sharing, where our wider ELSI network responded in one voice in saying, this is what our BBMRI, our biobanking community wants to have integrated into the principles that will be published. The same for EHDS. While the EHDS sits in the making, we've done it on our own. We've teamed up with others, especially with patient organizations, in calling here for absolutely integrating as well on the European level that patient and citizen voices are not only heard, not only integrated in the SEAP, but ideally also in the access committees. What it will mean in practice, as was mentioned in previous talks, we currently do not know yet. We can only speculate in big bits and bobs, and that is also the case for biobanks. Can BDMRI be an HDAC? Is it possible that we are on a national, maybe our national nodes, or on a European level, an element or even the data access point, or is a parallel structure because of the biobanking developed? Certainly, we need to engage and continue the dialogue that we have started, because the considerations I want to bring forward is that ELSI needs to be far stronger included in the conceptualization, design, implementation, beyond the mere compliance. We need both. It's not an either-or question. However, it needs to be done together and in parallel, linking to the aspects of fair, findable, accessible, interoperable, reusable principles, but by enlarging them with ELSI aspects. So the European health data space, of course, needs to be considered as a project in the making. It is unbelievably ambitious. There are some countries who have fantastic national strategies. Others, are still pondering about it. But the shared elements of this, at least from the ELSI perspective, is the risk, if we do it not right from the beginning, and not understanding it in a process, as also previous speakers have said, that elements are overlooked, that sustainability will not be given, because in the moment the public trust is lost, it's going nowhere. And what I wanted to say with from the risk element perspective, from space to the multiverse, it seems that we are creating rather more fragmentation rather than unification if we do not have these talks in parallel. And if we don't get it right from the start, we might lose it. The picture I want to conclude is we need to think, and actually I mean this in a positive way, we need to think of all the elements as a super tanker. The EHDS is on the rise. It brings a lot of good elements, but it will not be the jack of all trades that can solve all our problem in health data research. So we have to consider what we can achieve with it or not, because we cannot afford to stop it for elements where that cannot be completed, simply because it takes, as this example showcases, 25 kilometers simply to stop before the port. And with that, back to you in Toulouse.
Thank you very much. So thank you for giving us the point of view from an infrastructure of biobanks. You have heard about biobanks, and I don't know if you have a question.
But thank you so much for this presentation. I was just wondering, since you've started, let's say 10 years ago, we are not going to talk about the period before, so far away. Have you seen any evolution in the questions that were posed by genetics, and in particular regarding genomics, and the links with these legal, ethical, and societal issues, with the emergence of these new technologies that are at stake currently, and in particular this distinction between genetics and genomics, and how it has impacted the ethical questions in biobanks? Thank you.
Thank you for that question. I I think that they have been simmering there always, and they were black boxed for a while, especially with the bigger research infrastructure building, especially from the ethical and societal side. And the example from Denmark actually poses a beautiful example, because things were done, but suddenly the technological means, the combination of things make it ripe to look at things completely differently. And then the adjustment of the policies are very often only done when there is a scandal, when there is a consideration. With the EHDS, I don't see that it is yet happening, because the interoperability of big data sets being then combinable, coming from EHDS, coming from the public spheres, Twitter, coming from, or Twitter is dead, but that's another discussion, coming then from biobanks or multiple biobanks. That is a question that currently starts to be asked, but is not tackled, and in my view urgently requires a research project to really look into that, because the question is not if it happens, but when, that we really have to consider the consequences of it. I hope this answers your question.
So thank you very much, and when we go to our last speaker, which will be a bit shorter, I heard, and Cécile, it's a genetic counselor, and she has also education in social science, and she holds a PhD, let me get the right title, about the communication of return of results in the biobank in Estonia. And you have heard already from the start of this discussion that there were biobank studies very early on, population studies in Estonia, and now there is also a personalized medicine project, and so she will explain to us the situation in Estonia. Thank you, Liz.
I'm happy to be here. It was really interesting talks earlier. So I'll try to make it quick, just an overview of the Estonian initiative that was briefly mentioned before. And I myself am working at the biobank, which is closely related to the Estonian personalized medicine initiative, but it's just one of the partners of the initiative. And in the past few years, I've also started working at the personalized medicine and genetics clinic, because my background is genetic counseling. So wearing several hats. And here is a timeline of different events. Some of them, you can't really see the color code, but the orange ones are related to the biobank more directly. The biobank was created in 2000. And before we started recruitment, or the biobank itself was established, we actually had a biobank legislation created. And then during the first phase of recruitment to the biobank, where we recruited 50,000 participants over 10 years, the main messages were that the biobank is it's a great new national initiative for future generations. And one of the goals is to conduct genetic research, which in long term would benefit the public health. Whereas the later recruitment phase, where we recruited another 150,000 participants, the main message was more directly that it's for the personalized medicine initiative, which has actually made the difference between the two cohorts when we looked at even their demographics. And there are also several steps in the IT infrastructure that actually help us to provide the personalized medicine initiatives. But the personalized medicine initiative itself was sort of kicked off in 2014. And in the first few years, it was more about theoretical preparation. And then in the past few years, we've done clinical projects to investigate the ideas in practice. And so far, we're still preparing for actually implementing the services in clinical setting, not just as a research project. So, as I said, the first step was more theoretical, to analyze and strategize the feasibility of personalized medicine approaches in practice. And the discussion was what areas should be chosen for the first clinical trials. As part of the feasibility project was also investigating the public awareness and attitude towards using genetics in healthcare. And we could see that the public is interested in genetic information, but also luckily that they do see the value of health behavior as a stronger component in their health than genes. We could also see that they value physician recommendations, but also that there's even just general need for more information about what genetic services are already available and what are the limitations of genetic tests. And we could also see in this survey already that there was a strong link in the public's view between the biobank and personalized medicine. In parallel, there was also a study investigating the healthcare providers' knowledge and attitude, again, towards personalized medicine, and also trying to assess the training needs. And there we could see that they could see the potential value in genetics, but there was basically a great fear towards, based on the limited resources, that genetics is an expensive field, it would take economic resources, but also in terms of time in as the physicians' visits are already so packed with information, and they're just worried that when they have to explain genetics, it will make it even more difficult. So with healthcare providers, a few years later, or actually in 2020, around that time, we started with this workshop that was aimed at almost 1,000 individuals who provide healthcare. At first, it was primarily directed towards primary care providers, but actually we ended up also having some specialty doctors attend this course. And it also included practical exercises of some of the tools that we had been using in clinical trials. And in terms of trying to educate and share information out there, there was also established a newsletter on personalized medicine. Unfortunately, as the leading partner of this initiative has changed, the newsletter stopped at some point. And last year we established the Estonian Society of Personalized Medicine to bring together different partners. And so the first few steps were more theoretical in planning and assessing the needs and attitudes of different stakeholders. A few years ago, the two first clinical projects started, and basically the final product of these projects is is to assess the feasibility, the utility and cost effectiveness of these approaches, and come up with sort of a service model. And for in terms of first services actually planned now, the decision was to continue with breast cancer and pharmacogenomics at the time. And in those clinical projects, we have also always collected feedback from both the patients as well as the physicians who provided the services, just to map how their experience has been. Around the time of planning these first services, there was also an ethical legal analysis done. And I picked a few sort of decisions that came out of this analysis. Basically that although the biobank has been always used for this first clinical trials, when we talk about services in the healthcare, centralized healthcare in Estonia, it has to be, they have to be available for everyone, not just biobank participants, so they can't be limited to them. And currently the legislation is pretty much the biobank legislation, so we really need to work on legislation to also even to use the biobank participants' data in healthcare, for instance. And consent procedures have to be prepared for both versions of entry to the service, the biobank participant or someone who is not a biobank participant. And now in end of last year, there was also a new long-term plan prepared for the next 10 years, basically again looking at these different aspects. First of all, how to practically prepare the infrastructure to provide personalized medicine services, and also to how to address the needs of the public, how to educate them, and also how to address the needs of the healthcare providers, how to educate them, and also whether there's a need for new service providers or healthcare providers, such as genetic counselors. It's a profession that's currently limited to myself in Estonia, so basically it doesn't exist. The first services, as I mentioned, are including breast cancer and pharmacogenomics. It's a little bit related to my tomorrow's talk of an initiative that we started at the biobank, because I mentioned that services have to be available for everyone, so not discriminating the biobank participants versus others, but because it's centralized healthcare, we have limited budget, so the initiatives include genetic testing only for 40-year-old women, so anyone who's 41 don't access the service. And pharmacogenomics is limited to new diagnosis, so anyone who's had treatment before is not suitable. And also it just includes antidepressants at the moment. Yes, and back to the timeline. That's it from me. Thank you.
Thank you very much. Is there any point of clarification, question to Lise right now on the Estonian part?
Very quick. It's a very huge project in Estonia because your biobank exists since for a long time. And I have a question concerning your last clinical project. You question the notion of utility. how it was done in your project, as you had also breast cancer, pharmacogenomics, and so on. So, what did you do exactly? Do you remember?
I haven't been involved in those. Only the questionnaires for the participants, but that's one of the problems with the heart disease, for instance, the clinical utility. The heart disease project was dependent on health behavior change, which is very difficult to track the effect, which is why they continued with the breast cancer, because they're basically new diagnosis. Early diagnosis is something that is sort of an objective finding, but that's one of the reasons why the heart disease was not chosen for the service at the time.
Okay, I think we don't have too much time to make a general discussion, but I would like just to put some point and then see if there are some reactions. Through this overview of different projects, you have heard about biobanks, which are primarily related to research, both at country level and European level, to projects which are primarily going through the healthcare system, like our project in France. And in some countries, like Estonia and like UK, you first had big biobank, national biobank, and then it turned to the healthcare system. And I think there is a lot to learn from human and social science point of view on these different strategies, experience, and on where these sciences were actually involved, at which level, very operational, like a consent, and we need to do that to follow up, or is there something like a sort of accompanying research that can actually influence the governance and the way the projects are going on? And then something we discussed in the preparatory meeting between the speakers was about the funding, and there has been some question about it, also from you, Lene. We had in the committee of preparation of the program over the years of this meeting, discussions. Should we, when you have a line implicating human and social sciences in an initiative, should there be a funding besides? That has some logic, which is not the case in France. You don't have a funding for the research on human and social science. But we are supposed that thanks, we can organize these meetings to foster the research, but then it is not funded through the initiative. Some people say it's not normal. If we want to embed them, there should be a funding. Some others say, well, are we really free if we are funded by the initiative itself? Maybe it's not good, but then you need funding from somewhere. So there is this balance to attain, and at least posing the question, answering the question, maybe answering, but at least interrogating this issue from the point of view of the different sciences. What is a good model? Is there some compromise? Is there some sort of moral contract in order to, at the same time, guarantee the freedom of research, and at the same time having the usefulness, not the clinical usefulness, but the usefulness in terms of these very broad and expensive initiatives in order to take into account the different stakeholders. So that were my reflection about what we heard. I don't know if you can have a quick answer or if we just want to stop because we need to eat. Okay, so we pack a little bit. I would like to thank all the speakers, and please just thank all of them.